So today, our TA session is really centered around optimizing client access to telehealth. And we're really lucky to be joined by two individuals who have been working in telehealth for quite some time and who have some great insights around how clients can access telehealth and some of the challenges that they face around telehealth, and this specifically for HIV patients as well.
Our speakers today are Dr. Brian Wood and Dr. Javed Siddiqui. And rather than try to give you their bios, I'll just hand it over to Brian to introduce himself and begin the session.
Well, thank you very much to Anna, Marissa, and the Health HIV team for inviting me. Honored to be here. Thank you all for taking the time. Also honored to present with my colleague, frankly, one of my mentors over the years, Dr. Siddiqui. Dr. Siddiqui has taught me a lot, so thank you, Javed. I am an infectious disease and HIV provider in Seattle at University of Washington and our local Ryan White Clinic, and I'll be sharing some of our local experiences and a higher level overview of telehealth as it pertains to equity and access. Next slide. No financial disclosures. Next. So I think one thing that has become clear over the past year to 2 years, however long we've been in this crazy pandemic, since we've all worked so hard to disseminate telehealth, both video and audio visits, is that there are really dramatic benefits, not to mention helping people stay out of waiting rooms and off of buses and protect themselves and stay safe from infectious illnesses like SARS-CoV-2. There are a lot of other benefits that I want to acknowledge. Reduced transportation challenges, reduced barriers getting to the clinic, reduced episodes of missing work, child and other family care needs that have to be put aside to get to the clinic. I think there clearly are advantages to the individual. From a provider perspective, I think there also are advantages, and I've realized this in recent years, to me being able to see a person's home environment, almost akin to a home visit. I have gotten some really insightful looks into the lives of my patients, and I think that is a benefit. There are a growing number of publications over the last year or so documenting high overall patient satisfaction with telehealth, that being both video visits and audio visits, and we'll talk more about the distinction between the two. And there are some documentations about how telehealth can lower costs. So clearly there are benefits. Next slide, please. But what has happened and what we have noticed around the country since the pandemic began is as these efforts to disseminate telehealth have expanded, several important patterns have emerged. And I'm showing you here a slide from Lori Boucher-Pines and the RAND group that looks at all visits across 41 FQHCs in California from February 2019 to August 2020. And there's a couple really notable things here. I'll draw your attention first to the blue line at the top. This is the overall volume of visits for primary care and behavioral health. You can see in primary care, the overall volume of visits during the pandemic really didn't change. Behavioral health actually went up, actually saw an increased volume. But then if we break this down into the type of visits that made up that volume, look first at the orange line, and you can see the dramatic drop in in-person visits, not surprisingly, for both primary care and behavioral health. So then what made up that ability to maintain the overall quantity of visits? What accounted for, or what made up for that drop in in-person visits? If you look at the brown line at the bottom, that's video visits. The increase was really modest. The black line is telephonic or audio only visits, and that's what really increased. And I think that's a pattern that a lot of places have seen around the country. Telehealth has been utilized more than ever, but a lot of people are relying on phone visits instead of video. Next slide, please. We were interested in looking at that here in our Ryan White funded HIV clinic. This is the clinic I primarily work at. And you can see here a similar trend, a similar message. The height of the bars is the overall volume of visits per month. You can see there right in the middle where things drop off. That is when our shelter-in-place ordinance went into effect. We were hit pretty early and pretty hard here in Washington State, and by April 2020, we were encouraging everyone to get on video visits. But despite encouraging video visits, despite a lot of efforts to help get everyone on video, despite all the legislative changes to support and pay for video visits, you can see here our uptake of video visits was again pretty modest. Videos in blue, orange is audio only telephonic visits. So again, a lot of people relying on audio only. Next slide. And so what's been observed is what has been called the digital divide, or this inequity, this difference in access to virtual healthcare, a difference in access to telehealth, in particular to getting on video visits. And this has been observed by all around the country, frankly, all around the world. This is one example of a publication from a provider who just noticed this was happening in the community. So this digital divide or inequity in access has been defined as the gap between individuals who have access to modern information and communication technology and those who lack access. And it's not unique to medicine, as I will come back to. Next, please. Thank you. So one thing I think we have to acknowledge is, as we have pushed for a dissemination of telehealth since the pandemic started, there is this risk of widening or worsening this gap between those who can get on telehealth, can get on video visits, can get on MyChart and other virtual healthcare tools and options versus those who cannot. And that is what I'll focus the rest of the talk on, is that inequity or that divide in access and how we might address it. There are a couple other of risks that have been talked about and written about with telehealth that I also want to acknowledge and would love to hear your opinion on. One is exacerbating our implicit bias as providers. Again, we are seeing the home environment. So I think we have to ask the question, do I as a provider treat someone different if they log into their video visit from a very nice home versus from the street or their shelter or other locations like that? Luckily, there are some very smart researchers looking at that and trying to answer that question of whether people are treated differently. And I think it is an important question. It has been raised that there's concern that telehealth, whether it's video or audio, will lead to lower levels of personal care, rapport, or trust with patients. I think we need to be aware of that, be cognizant of it, and work to make sure that doesn't happen. My own experience has been that those patients who I've known for a long time, I really don't feel any difference in the rapport or trust over video. Sometimes we actually sort of laugh about it and connect, and I think it's actually kind of helpful, but I may not do my first visit with someone by video unless they really want to. Maybe my first video, I will want to, see them in person and start with that rapport. So I'm in no way arguing that every visit should be by video, but I would argue that everyone should have the option of doing a video visit or doing telehealth if they want to and if providers feel it is appropriate. It's also been raised that telehealth may reduce quality of clinical care, such as limiting a physical exam. And again, I think that as medical providers, we have to decide when a video visit is appropriate and when an in-person visit really is necessary, either because of the conversation to be had or the physical exam that's necessary. One challenge I also want to highlight that I have experienced since doing more and more telehealth during the pandemic is just a challenge coordinating labs and other things. And I think there are creative strategies and solutions to try to get around that, but it's also something we need to be aware of and be intentional about and think about ahead of time. And then not about your clinic, but in our clinic, the efforts to help every patient get set up for video visits has added some administrative burden that, again, I think we need to acknowledge and be intentional to address and plan for. Next, please. Now, one thing in terms of access, and I think we've all experienced this as providers, people who schedule a video visit really want to get on video, but then either have challenges because they don't have enough data or they don't have the bandwidth and the video or the audio is freezing, or for whatever reason, they just can't get on, or they're frustrated with the technology and not familiar with the technology. And I think stepping back, it's really important to recognize that there are a lot of different things necessary to be able to successfully interact with virtual healthcare, to successfully get on a virtual visit. So a device, of course, is important, but not just a device with enough data and then a reliable broadband connection. That is really, really important. And I think more than ever, it's not the device that tends to be limiting people, it's these other factors. There also has to be a degree of technical literacy. Unfortunately, a lot of technical tools really are designed for English language speakers, and those with limited English proficiency are going to have more challenges. Privacy, this is something Dr. Siddiqui and I have talked about and have both observed in our practice. Privacy is a really important and precious commodity that not everyone has. And I've had people log into video visits from shelters, from their car in the parking garage trying to hide from work, from the bathroom at home trying to hide the conversation from housemates, walking around downtown because they had nowhere else. So privacy becomes a really, again, important commodity. And then the social support, the older individual who has some younger family at home who can help them get on video is going to have an easier time than the person who is more isolated. A lot of people in our HIV clinics that don't have that level of support. The picture at the bottom right is actually a story Dr. Siddiqui alerted me to from August 2020. You can see here an image that was published that is two young individuals trying to get on school. And you can see here, I show this as an illustration that having the device is not the issue. It's the broadband, it's the internet connection. And really the device was not what was needed here. This problem was solved by giving the family an internet hotspot with reliable broadband. This is where infrastructure bills and things to expand the broadband opportunities and connections around the country become extremely important. So again, this digital divide is not unique to healthcare. We could easily be talking about it with education as well. So all of these could be, and I would say should be, considered social determinants of health. Next slide, please. Since the pandemic started, a number of clinics around the country have tried to ask this question of who is succeeding, getting on video and using telehealth and who is not. These are some examples published in the literature from a couple from UPenn, one from Mass General in Boston, where they simply looked at who is using various modalities of telehealth based on social determinants of health. And you can see there that certain social determinants of health do seem to predict utilization of any telehealth or any telemedicine, and in particular, video. Next slide, please. We looked at that here in our Ryan White HIV clinic and simply asked the question, what factors, what social determinants of health are associated with having success with at least one video visit since the pandemic began? And there's some limitations to this data, which I will highlight, but I do want to show you that in our Ryan White HIV clinic, it seemed like age 50 to 65 or above 65, as compared to 18 to 35, was significantly associated with never having a video visit, as was non-white race compared to white race, as was Medicaid insurance compared to private insurance. Those were some of the big factors. The other one that really came out in this is patient portal login. If a person had ever in the past successfully logged in and used our MyChart patient portal, that was significantly predictive that they would use successfully at least one video visit. Maybe that's not surprising, but I do think it's an important marker that a person is prepared for and can get on video if they've ever used their MyChart portal. We tried here to look at a few other social determinants of health, things like gender and income and geographic location, and we just didn't have the data. So I think some suggestion here that social determinants of health predict likelihood of successfully using a video visit. And I think this begs the question of why are there these differences? Is it access to technology, language, and comfort using the technology? Or one thing we don't really know, is it preference? Are some people more likely to prefer in-person than prefer telehealth? And I think that's a question that needs to be asked, and people are asking that. Next slide, please. So again, I think there is this risk that as we propagate telehealth, we will worsen this digital divide and these inequities. However, if we acknowledge that and are intentional about it, I think we can overcome that and really see this as a time of opportunity and a time to bridge this divide, close this divide, and help make sure that everyone has access and at least has the option of doing a telehealth or video visit. These are some articles that have been written about this opportunity and how to do this. One I had the honor of writing with Dr. Siddiqui in our IDSA telehealth work group, and there are others in the literature as well. So what should this look like? What should we be advocating for, and how can we bridge this divide? Next slide, please. I think there are a few things from a policy perspective we should be advocating for. Once the public health emergency ends, I really hope that there will be this opportunity to continue to offer telehealth and especially video visits, but also audio only visits as a backup, as a key kind of critical access safety net, if you will. So I think there are some policy changes we need to advocate for. I again think we need to better understand the barriers and also the preferences. I argue that everyone should have access and an opportunity to get on video if it makes sense for them, if their provider feels it is appropriate. And I think we need to better understand why not everyone is getting on video, and importantly, why some people are falling back on audio only. Is it access? Is it preference? Is it other? I don't know about you, but I've also had the experience where a person tries to get on video and it's just not working, and then we fall back to audio. That happens, not uncommonly. I've also a couple times had a person say, no, I don't want to mess with the video. Let's just do audio. And so we need to better understand those barriers so we can address them. Next slide, please. So these are some examples of quality improvement interventions that look to improve access. This is not an exhaustive list. In the Q&A time, I would love to hear your local experience. What have you done locally or seen done, or what are you trying to do to help make sure everyone has access? These are some examples, though, to stimulate ideas and thought and conversation. So one is standardizing a telemedicine checklist, trying to go through this checklist with every patient, either when they come in or when they schedule a visit or schedule a video visit, to make sure that they are all ready for the video visit and that barriers can be addressed, testing visits beforehand. And I think, again, there are different ways to do these things. It can add administrative burden. So trying to figure out who in your clinic will take charge of this, or if there is no one, trying to find someone who can. Early in the pandemic here, we had a great group of med student volunteers who did this, who reached out to people ahead of their visit and made sure they were ready for their video visit and could get on. But standardized checklists and testing visits goes a really long way. Now, again, some people need a device, and if there's a way to give them the device, that may solve a barrier. But I also want to emphasize that sometimes it's not the device, it's the internet connection, it's the broadband, or it's having a private location. So sometimes giving headphones can go a long way. We have worked to set up some telemedicine stations at local case management agencies, so that if a person doesn't have the ability, they don't have a device, they don't have broadband at home, they can go to their local case management agency where there's already some trust and rapport, and can do their video visit with their provider from there. We've also worked to set up stations at our local libraries. We have a great collaboration with our local library system where a person can go and do their video visit from there. I really like working with the local case management agencies and local CBOs, because the patients may have pre-established trust and rapport there and be comfortable going there to get help getting on their visit. But also working with library systems and others, I think, is a great resource. There are examples of telehealth training kiosks you can set up in your clinic or set up in your medical center, a place where a person goes and takes their device and gets some help. Telehealth interpreters or navigators are becoming more and more common and can be extremely helpful. Making sure interpreters, including sign language, are integrated into your video visit options. I don't have time here to go through some of the accommodations for telehealth for people with disabilities, but I put some resources there at the bottom for you to look at. There's some great recommendations and resources there. Making sure all of your instructions for video visits are in multiple languages, and making sure that they are provided by simple platforms. So we make sure, for example, that our link to telemedicine visits here goes out not only through our MyChart system, but also just by SMS, just by text, because a lot of people have more success that way. And then I think a big one is including telehealth usage gaps, these inequities and differences as performance indicators, creating dashboards. That's another thing we've done here. It's been said that, if it's not measured, it's not going to be changed. So we got to measure it so we can see the discrepancy, understand it, and then institute change. Next slide, please. This is an example of a telemedicine checklist, which we certainly can share and you can adapt for your usage. This is another thing that Dr. Siddiqui and I worked on together with our Telehealth and Emerging Technologies work group. Next slide, please. And so finally, I will wrap up and then turn it over to Dr. Siddiqui, who can fill in a lot of details and share his experience, and we would love to hear your experience as well. As a community, we need to consider telehealth access as a social determinant of health, promote what has been termed digital inclusion, making sure everyone has access, better understand the risks, the barriers, and work together towards solutions. Another thing we've done here at the university is to create a collaborative effort where we get together regularly, not only medical providers, but also individuals from bioinformatics, from psychology, everyone who is interested in inequities, bias, and improving these gaps in care. We get together regularly to discuss and work on these projects together. So bringing like-minded individuals with similar efforts together, I think, is how we will help to solve this problem. I will close there and turn it over to Dr. Siddiqui. Oh, there are some references on the last slide. Please feel free to take a look in terms of general telehealth resources and some specifically on the inequity issue. Javed?
Well, thank you. And we'll turn it over to Javed.
Thank you so much, Dr. Wood. Always a pleasure listening to you, and big shoes to fill following you. So I've been actively doing HIV-based telemedicine since 2002. I was initially at the University of California, Davis, and then went into private practice and started an organization called Telemed2U, and that's where I am right now. Next slide, please. So my disclosure, well, I kind of take a different view of disclosures because I feel like, disclosures are what actually may bias you. Well, I have no financial disclosure, but I make my living practicing medicine. I believe in telemedicine and telehealth. And like I said, I've been doing this since April 2002. So there is some bias because of that. Next slide, please. All right. So telemedicine, it's kind of not new. This is the Jetsons, 1962, right? Elroy is sick, and Judy, his mom, gets a telehealth visit right in their home. Now, I can't understand why the doctor's wearing a mask, but that's a whole different story. But you see, this is what we've been trying to do with telehealth all along. And home visits kind of has been the last mile of telemedicine. And if you can say something horrible, like there's a positive that came out of this global pandemic, well, being able to see patients at home really has been one of those. Next slide, please. Okay, so let's talk about telemedicine in the age of SARS coronavirus 2, otherwise known as COVID-19, please. Okay, so it's House Bill 6074 and the CMS Public Health Emergency really are the things that changed legislature and changed compensation that allows us to do what we were, Dr. Wood and I are talking about. Next slide, please. Okay. So these are the restrictions and the penalties and the reimbursement. It's really small writing. Next slide, please. So this is what it really means, okay? It means that the home can be an originating site of care. We've never had that. CMS has never allowed the home to be an originating site of care. So that's a huge change. In addition, CMS and Medicare suspended the Metropolitan Service Area exclusion rule. What it meant was if you were in a designated Metropolitan Service Area, you couldn't bill for telehealth services. You had to be in a rural area, and that was left up to CMS to decide. So the fact that both of those were suspended during the pandemic has really allowed us to be able to do what we're doing now. And the good news is that the Public Health Emergency, or PHE, has been extended to December 2022, December 31st of 2022. Next slide, please. Okay, so do you practice telemedicine? Next slide, please. Right? So, Dr. Wood showed many of these slides, but this is the growth of telemedicine. And you can tell it wasn't subtle, right? We know that March, the second week of March, was an absolute explosion of telemedicine. And what you see, the black is primary care, the blue is medical specialties, and the yellow is surgical specialties. Next slide, please. Yeah. And then when you ask individuals ages 50 to 80, have they done telemedicine before, May of 2019 was 4% and June of 2020 was 26%. And it really turns out to be 1 of 4 older adults had a virtual visit during the first 3 months of COVID-19. Right? Next slide, please. Okay, so let's talk about telemedicine, a little bit of the basics. Next slide, please. Okay, so when you're talking about doing telemedicine, and those of you, if you're doing it or wanting to expand your program, this is a little bit of a more global view to take a look at it. What do you want to do? Do you want to do inpatient? Do you want to do outpatient? We do both. You want to make sure you're high tech and HIPAA compliant. What are your hardware requirements? What's the compatibility, right? What's the ease of use, right? Are you connecting to a home-based patients, or are patients coming into a central clinic and you're meeting them through telemedicine there? Interoperability, if that's important to you, and obviously cost. Next slide, please. So from the hardware standpoint, what are your patients going to be using and what are you using? Computers, smartphones, tablets, and it matters what operating system you're on, and headphones. Now, I know you're going to think I'm crazy about this, but next slide, please. All right, so I'll get back to headphones in just a second. So Dr. Wood touched on this, broadband, right? Just saying that you have internet connection doesn't mean you have broadband. And you go, well, what's the difference? Well, most internet connection is somewhere around 12 to 16 frames per minute, right? And that gives you a little bit of an audio video disconnect. If you get 24 frames per second or greater, that's when you have real audio video like we're meeting today. So broadband really is important, not just having access to internet, because it may not have the bandwidth in order to support video. Next slide, please. All right. So what are some of the key issues, right? When we talk about the fact that in healthcare, privacy is so incredibly important, right? We're talking to patients about HIV. Maybe they don't, I see patients who are in shelter because the shelter is the only place that they can get broadband connectivity, right? It's home-based telemedicine. Well, maybe they don't want the kids to hear. Maybe they don't want grandma, grandpa to hear what's going on, right? And then obviously we already discussed about the Wi-Fi issue. Next slide, please. So let me get back to the headphones. This is why headphones, I think, are incredibly important for our patients. And we really, really encourage all of our patients to use headphones unless they're living by themselves. And what it does, it creates a realm of privacy, right? So my patients who are in the corner of a shelter and I'm seeing them and going over their HIV results, we can have a private conversation, right? Same thing whether they're at home or any type of environment, right? However, I will tell you, we do not see patients at coffee houses. We do not see patients, when they're driving, and we do not see patients when they're in the grocery store or any other type of store. So, still want to have some decorum. Next slide, please. Okay, and Dr. Wood talked about that, and I think we've touched on this. So, again, that whole idea of broadband and the digital divide. Next slide, please. All right. So when you talk about doing telemedicine, one of the things that I talk about is digital literacy, right? So I'm going to break this down between the providers and the clinic. One of the key things I think most people realize is that doing telemedicine is not about downloading a video platform like Zoom and having a camera on your computer and, hey, you can practice telemedicine. There really has to be some training involved in it, right? Again, what type of patients are you seeing? Do you have EMR access? What hardware are you using? Do you have broadband? Again, with the headphones. Do you want to use headphones as a provider? Camera, how good the quality is your camera? How good is your lighting, your microphone? And how good is your digital presence? Because remember, if you're not comfortable with the media, being on video is not going to make you come across as being comfortable. It's actually going to enhance the fact that you're uncomfortable with it. And then if you're uncomfortable with it, your patients are going to be uncomfortable with it. And this actually brings up a point. I apologize. I'm out of my office today. So that's why, I don't have the optimal lighting. But if I was in my office, I would. Next slide, please. Now, again, this is a big part of digital literacy. Okay, because remember, this is what the patients are seeing. And do you want your patients to see that you're out on your back patio, that you're in maybe a slightly messy kitchen? The gentleman down there, the lighting is not very good. All of these things impact how comfortable you are and how comfortable your patients are. So remember, just like you're getting a window into their world, they're getting a window into your world, and it's up to you to decide what kind of window or what kind of scenery you want them to see. Next slide, please. All right. So the other things to consider about when you're doing telemedicine, right? It's about obviously your lighting, your audio. You want to avoid windows, right? You don't want someone to think, well, they're seeing me and someone walks by and they can see who they're seeing, right? Patterns of clothes, right? Plaids and checks really don't come across on video very well, right? And again, I have to say the comfort, your comfort level with the medium. And one of the things I really encourage people to do is when they're starting to do telemedicine is to practice, right? Connect to, connect to your staff, connect to your friends, just really get used to the medium so you're not screaming at the computer. I have several providers who, when they first started doing telemedicine, were actually screaming at the computer screen because they go, well, I don't know how good the audio is. Audio is excellent. You don't have to scream. You're scaring everyone. Okay, next slide, please. Okay, I think we've already covered this. Next slide, please. Okay, again, with regards to providers, I mean, if this is your workspace and you love entropy, that's wonderful. Do you really want your patients to know this is what your office looks like? You have to decide that. Next slide, please. Okay, so now let's talk about from the patient standpoint. And again, patients need training as well, right? They need to know you don't have to scream. We can hear you very well. We really want you to wear headphones because we want you to have privacy, right? If there's labs or X-rays, the doctor's going to show you that on the screen, right? You also want to make sure you know where the patient is being seen. Is it a home? Is it a clinic, right? Also, with regards to camera, lighting, microphone is all important for the patients as well. And I think I want to continue on what Dr. Wood was saying. We're getting an insight into their world, right? Well, which we never have, right? And I think that's incredibly important. I tell you, one of the things that we've seen that's been incredibly beneficial of seeing patients at home is our patients who have diabetes and our nutritionists who are meeting with them because they go, come on, walk over, open up the refrigerator, let's see what you got. Let's go through your pantry, let's see what you got. Oh my goodness, you've got all this soda, no wonder your blood sugars are high. So it really gives us an insight into their lives and their world, and it can shed some light into maybe issues with compliance, maybe issues with food, etc. Next slide, please. Okay, so building rapport. How do you build rapport? Okay, the most important thing is being comfortable with the medium. If you're not comfortable, they're not going to be comfortable. And also, don't be afraid to answer their questions, okay? Because if you get irritated at their questions, that again doesn't build rapport. And some of the most common questions are, is this being recorded? Right? Can anyone else hear me? And is there anyone else in the room? And that is so incredibly important. If you're at your office and a medical assistant or a nurse or a colleague walks in, you really should say, oh, Mr. Jones, one of my colleagues that I share the office with just walked in. Don't worry, I've got headphones. They can't hear you, but I just want you to know, right? Again, that is just respect, and it really builds rapport with your patients, right? And then I think one of the things that we do that I think is very important is like we ask the patients, how did you like this experience? Did you like being seen through telemedicine, right? Did this help you? Do you prefer this, or do you prefer an in-clinic or an in-person visit, right? And I think that allows you to better understand what their concerns are, right? Well, I'm really concerned about this because I'm concerned someone's going to hack into the line and they're going to hear all my health issues. Well, let me allay those fears to rest. The software that we use is actually encrypted. It's dual encryption. It's encryption at the patient side and encrypted at the provider side. So if anyone was to hack my internet, they're going to get buzzed. They're not going to see anything. If they hack your internet, they're not going to see anything because it's encrypted. So we want to make sure patients realize that their confidentiality is absolutely being upheld. Next slide. So the other things you need to talk about is how often do you want to do visits, right? How often do you want to see the patients? And I think it's important to communicate that with patients, right? And that's an absolute individual decision between you and your patient, right? What's your practice structure, right? Are you going to use telemedicine to share lab results, share X-ray results, check in on your patients, do ancillary care such as nutrition, or are you going to be using telemedicine in order to actually deliver healthcare and review their medications and possibly prescribe them new medications or order new labs? What are you going to be doing? How often do you need to see the patient? I think it's really important that you think about this before doing telemedicine. And I think it's also important you convey the patient with regards to this as well. All right. Next slide, please. Oh, one last thing I'd like to say is about the triage. I think triage is incredibly important, and we're not utilizing this enough. So as we head into influenza season, right? If your patients call up and go, boy, I'm just not feeling good with a respiratory infection. Do you really want to bring them into your clinic and have them sitting in your waiting room? Why not connect with them through telemedicine, see how they're doing? Oh my gosh, you've got coryza, you got a runny nose, you've got a cough, you feel aches and pains, and this came on all of a sudden. Well, this could be influenza. Let's send you to the lab. Let's get a swab. Let's do this. So you can really triage the patient from home as opposed to having them come in and possibly exposing other patients and staff as well. Next slide, please. Okay. So one of the things that everyone talks about is physical exam. I mean, it's probably the number one question I get asked by providers. How do you do a physical exam? I just wanted to offer this reference. Dr. Lukowski and colleagues at Mayo Clinic published this in August 2020, really, really comprehensive paper on how to do telemedicine-based musculoskeletal evaluation. I think it's really, really worth a look. I think it's one of the best papers ever written on the topic. Next slide, please. So this is how we work in hospitals, right? So sometimes we have these robotic telemedicine platforms. They actually have a digital stethoscope. I've got 20 to 40 times optical zoom. I've got handheld ultrasound. I have nurses and physician extenders to help me. So at the hospital, it's a lot easier to do all these things. And I can drive around to the ICU, to the floors, everything. Next slide, please. Or are you doing clinic-based, right? And the clinic-based, you probably have sophisticated telemedicine equipment with digital stethoscopes, dermatoscopes, and you have MAs and nurses who can help. I have some of the same telemedicine resources here that Dr. Wood had in his presentation. Please, next slide. Right. Now, what about home? Okay, so you're seeing a patient at home. We know there's going to be limited equipment, right? Maybe you get vitals, maybe you don't get vitals, right? Maybe all you can do is just inspection type of exam, or maybe you can have the patient get up, move. If they're complaining of some musculoskeletal activities, you can have them stand up, do some maneuvers. But it's very different, and you need to be prepared for that, right? It's very disconcerting if you go, oh, I'm seeing you at home, there's no vitals. Okay, let's see if we can do this. That doesn't build a rapport. That doesn't breed any type of confidence in your patient. Right? But with your patient, I should say. Next slide, please. So what we've done is we've actually utilized, we've been doing this for quite a few years, a lot of the apps that are available. If people have a smartphone, and I know, that there's a cost associated with it, not everyone has it, but if they do, ask them. There are free software that you can download that will do vital signs for you, right? We use it quite a bit, and it allows you to get some vital signs for patients at home. Next slide, please. This is high end. I completely understand, but I think a lot of people who have the means are purchasing this. This is Tyto Home. This allows you to do otoscope, ophthalmoscope, look in the throat, and projects and interfaces with your telemedicine platform. And as you see here, mom's putting the otoscope in the child's ear, and the physician is seeing the tympanic membrane. So it's wonderful, but again, yeah, this is about, I think the base model is about $99, and what I'm showing you here is about $200. I have no financial interest in Tyto, just want to show you what's available out there. Next slide, please. Okay. This, I think, is completely underutilized by healthcare professionals, right? And I completely understand. There's cost associated with it. Not everyone has these, completely understand. But they may have something like it, whether it be a Fitbit, whether it be a Droid watch, something like that. Obviously, this is the Apple Watch, right? Their tagline is the future of health is on your wrist. So you can get vital signs. You can even get a 1-lead EKG. You can get pulse oximetry. You can, in some of your patients who may have some of these things, you can really utilize it. So I think you really have to be creative and look at ways that you can get vital signs when the patient's at home, and not just say, well, you're at home, we're not going to have any vital signs. They may be wearing an Apple Watch, and you have access to all these vital signs. So next slide, please. Right. So really, what is the workflow, right? The workflow really is we contact the patient. We make sure that they understand that it's going to be a telemedicine visit, that they, so we schedule the patient, right? And we also make sure that our team, what's their hardware, what's their software, what do they have, what location they're going to be in. They do a test call to look at how good their internet connectivity or broadband connectivity is, make sure that the audio works well, give them a little bit of guidance on digital presence. And so all of that is done before our provider or our physician ever sees the patient, right? That's done by our staff. And I think that's incredibly important and also helps build that rapport and that confidence. Oh, this clinic has done it before. Oh, this clinic really knows what they're doing. These guys really understand about telemedicine and telehealth. Okay, I feel comfortable about this. Next slide, please. So again, one of the things that we do is we assess the telemedicine readiness of our patients, right? We do the test call, like I mentioned, and then we always ask for patient satisfaction. We actually push them out a survey. We actually have an over-the-counter application that sends a text message right to their smartphone, and they can give stars or thumbs up, and they can say add comments as well, because we think that's really important. And then we also ask our providers, how was the telehealth visit? And I think that's one of the keys. You've got not only look at satisfaction from the patient standpoint, but also look at satisfaction from the provider standpoint. Next slide, please. So what's the next phase? Well, I really do believe, and trust me, I've been a believer of telemedicine when people told me that this was one step away from medical malpractice, right? I really do think that what's happened in the last 18 months is that we're definitely going to see telemedicine integrated to all types of healthcare. I really don't think we're going to put the genie back in the bottle. So I think it's going to give our patients a lot of opportunities to access healthcare where they haven't been, and give providers ability to connect with their patients in a way they never have before. Next slide, please. So with that said, I think I met my time requirement. So really look forward to the questions. Thank you again for allowing me to participate in this discussion.
Excellent. Thank you both so much. And you definitely both got right within the time. So I appreciate you keeping to that so we can ask some questions. So I just want to let everyone know that's on the line that you can either post a question in the chat, and Anna and I will ask the question, or you can come off mute. And while you're thinking about questions, I just wanted to kick it off, and I have a couple of questions around the workflow piece, which I found very interesting and obviously is very different on telehealth. Both of you mentioned kind of the pre-visit test checklists and testing, and I'm just wondering who what types of providers or staff members are the ones that are conducting those test calls, and how does that work? So who does it, and what does it look like for you?
Dr. Wood, please.
Well, I'll start, and then Javed, please share your experience. So our process really is, it's the front desk admin staff that calls, checks the person in, double checks they know when they're going to log on, double checks they have the device and have all of the info. The actual test visit process has evolved for us over time. Again, early on, we had some volunteers doing it. Now it really is front desk administrative staff. But as I mentioned, I think we do have to acknowledge the added burden of that. So I don't think it has to be done like that. I think it could be any number of individuals, and really depends on clinic staffing and availability. But Javed, what's your experience been?
Absolutely same, Brian. We actually have staff that we call telemedicine coordinators. Our organization is predominantly telemedicine based. So when they make the appointment, they hand them off to a telemedicine coordinator. And some of the telemedicine coordinators are MAs. Some of the telemedicine coordinators are administrative individuals, but they've been doing this. And what we have found is that the more comfort that our staff has at doing these and recognizing some of those nuances, the better things go. So,
if I add one more thought to that, Marissa, I do think more and more centers are developing a role that is telehealth navigator or telehealth interpreter. And I think we're going to see more of that, as Javed was saying, individuals who really are trained and dedicated to doing this.
Absolutely.
That's great. And just I'm glad you both mentioned that, because actually a plug for our next TA session, we will be having a telehealth navigator co-presenting around client, more around kind of the patient experience. So Yeah, I think that's a great resource if there's access to it. I just have one more question. We'll open it up to the group. How has it affected the timing kind of in your day? Is it helping you see more patients throughout the day? Is it elongating because maybe you spend the first couple of minutes doing kind of can you hear me? Can you not hear me? Answering questions about the video visit, etc. So what does that look like? How has that affected how long you can see or engage with a client?
John,
Brian, please.
why don't you kick this one off, John?
Okay, I will. So, the first visit, yes, there's a little bit of, probably 1 or 2 minutes, a little bit longer than you were in a bricks and mortar environment, but it's not really about how much the provider is seeing the patient. For us, is how many telemedicine allows the patient to have more interaction with the clinic. And it doesn't matter whether it's me, whether it's an MA, whether it's a nutritionist, whether it's one of our pharmacists, it allows the patient to have much more contact. Right. And, we do medication adherence programs in our HIV patients. If they have a question regarding drug-drug interactions or side effects, they can always contact one of our pharmacists they're on. So it's really been wonderful to allow our patients to have more access to the services our entire clinic provides. Now, one of the things that we do that may be different from other people is that we don't mix bricks and mortar and telehealth. Right? We have a telehealth clinic, and if one of our providers is a bricks and mortar is a separate time. So they'll do 8 to noon telemedicine, and they'll do 1 to 4 bricks and mortar, or vice versa. But we try not to mix the two. At least for us, we found that's not necessarily the best way. Brian, please, what do you all do?
Sure, largely agree. And I guess the one difference in the model would be that last piece you said, where ours is really just mixed and integrated. And during my clinic day, I may have a mix of in-person and telehealth visits. It really hasn't changed my volume of visits or my availability in any way. Yes, there are those moments where I'm trying to help somebody solve the technical issue and get on, but in general, it really hasn't changed my volume. An interesting thing is I'm seeing more and more data and presentations lately on how no-shows have actually gone down with the expansion of video and phone visits. And I think in that way, access is probably actually better than it was. That seems to be a fairly consistent finding when looking at no-shows. We haven't looked at that locally. We may at some point. So I think that's another important thing to consider.
You bring up a great point. I'll give you one example. Our nutritionist had a 40% no-show rate. Since we were able to connect with the patient at home, the no-show rate has dropped to in the teens now.
Wow.
Yeah.
Yeah, so even if we're not expanding our number of visits, I think we may be reducing no-shows, at least for certain individuals.
Great. All right. Does anyone else from our cohort have any questions? Feel free to come off mute if you do.
Hi, this is Latoya. I'm curious about how the determination is made when someone needs to come off telehealth to in-person or vice versa.
Latoya, this is Brian. Appreciate the question. Can I make sure I heard you correctly? The audio was a little soft. It was going between telehealth and in-person and back and forth. Was that right?
Yes.
Java, do you want to start that out?
Sure. I think for us, it really depends on if there's a procedure, right? Or if there's something urgent. I mean, obviously, someone's cut themselves, telemedicine, not going to be all that useful, maybe to triage, but not much more than that, right? Or if someone's having chest pain or things like that. What we've really found with regards to specific to HIV care has really been a combination of both. We don't exclude one for the other, right? So if there's something significant going on, obviously, if we have to deliver news such as malignancy or something else, if at all possible, right, we'll ask them to come in, and if they can't, then we ask them, if they have someone, some support, emotional support there while we deliver the news to them. But outside of procedural based, then it's really up to the situation, individual situation. But we don't look at it as an and or. We look at it as, both of them have a role and how can they play together. Please, Brian.
Couldn't agree more. I think it is a individual by individual and honestly visit by visit decision. Is it appropriate? Is this a routine every 6-month follow-up where we just need to chat and a person can get labs done at a local lab and they can be faxed to me and they don't need to trek in, to come see me? Or is there an acute issue? Do I really need a hands-on physical exam? Is it a difficult conversation that I really want the person there? And so I do have a lot of people who might see me now, once a year in person, and then they'll do a couple follow-ups by video and they'll request in person if they really want to. So I think there's no hard and fast rule in my opinion.
Thank you.
Thank you for the question.
It's a really great question.
Other questions? Oh, go ahead.
No, this probably isn't my role to pose a question, but the coordination of labs I have found challenging, and I imagine others in the community and audience has. And I wondered, Javed, what your strategy has been for the telemedicine visits, for example, the routine every 6-month HIV is coordinating labs. What have your tricks been?
Absolutely happy to share that. During COVID, labs were incredibly difficult, right? Because patients had to make a specific appointment at the lab in order to go in, and they were only allowing 6 visits per day, and it was very, very difficult. A lot of labs didn't get done. Now, it's actually, or pre-COVID and now, it's a lot easier. So what we again, part of our pre-visit is we ask our patients, right, what's near to you to get the lab work done? What's your pharmacy, right? And if they go, well, I have no idea what's near to me from a lab, and again, no financial interest in not promoting them. We primarily use Quest. So our team gets on the Quest website, looks for the site nearest to them and go, oh, is this one? They'll go, oh yeah, it's only 2 blocks away. Okay, great. We're going to send your labs there, go there and get your lab work done. So, but do we have to remind patients to get their labs done? Absolutely. I mean, it's, yeah. It's an added dimension, but something that we can do. And actually, what we've done is we do a lot of SMS or text messaging to our patients, or emailing them if they don't have a smartphone, and say, "Hey, did you get your labs done? You have an appointment coming up in 2 weeks." Try to send them reminders like that.
Thanks for letting me pose a question. Sounds like similar experience, and it's good to hear, Javed.
It's Latoya again. I'm sorry.
Please.
That gave me another question, actually, kind of within the same vein. So, what about how does? Let me phrase my question. Sorry. I want to find out what the process is if you have a patient that you have to do a follow-up on and you're not reaching them. You've had, experience with being able to connect with them before, but maybe you had to give them some bad news. So this is someone who is diabetic now, where they weren't before. And you're trying to connect with them because their A1C is way off, but you can't, have you had trouble with that at all? And if so, how were those kinds of issues how were those type of challenges addressed?
Brian, please.
I'll start with some thoughts. I don't think there's an easy solution to that. Yes, I've had that experience. And I think strategies have ranged from, trying to reach out by text, by email, by other forms than just phone calls, because sometimes, especially text, is just more successful. And then if all of that is not successful, trying to reach out through case managers or through other networks to try to connect with the person. And then again, once we do connect, figuring out, okay, what is the appropriate next step? Is it an in-person visit to have this conversation? Is it a video visit, a phone call? But I hear you, and it certainly can be challenging. Javed?
Been doing this for a while, and I have, through video conferencing, I have told people of their HIV diagnosis. I've told people of their AIDS diagnosis, malignancies, you name it, we've done it, right? And it's not because we didn't want to bring them in. We take care of people who are maybe 4 or 5 hours from a bricks and mortar clinic. And it's just not feasible for them to come in. They don't have the ability to come in. So, I think it's, again, your comfort level with the medium, and I think your comfort level with delivering the information, because I personally do agree that you can deliver these types of information in a very respectful and very caring way. And I think again, you want to make sure that, if it's, incredibly earth-shattering news, you may want to ask them, hey, do you have anyone there with you? Is there someone to give some moral support? Do you want your partner involved in this conversation? Things like that.
Awesome. Thank you. Oh, and I have one other question if I can.
Please, no one else is asking. Go ahead.
And it's always funny. My mom told me I was from White Child growing up. I was just wondering if, oh shoot, now I think I forgot my question. What was I about to ask you? It was within that same vein. Oh, the medium thing. So, does either of you have a specific program that you feel like works best for telehealth?
A platform, a video interaction platform to use?
Yes.
Javed, maybe I'll give real quick and then see what you think. I think there are quite a few available now, and as long as they are HIPAA compliant, I don't think there's one right option. I work at one clinic that uses Zoom, the HIPAA compliant version. It feels very similar to what we're on. It's nice because people are familiar with it, but I don't think it's the most user-friendly from the patient end. I work at another clinic that uses Docs. There's another one called Doximity. Some are really just one click and you're on, and I think that has advantage. But personally, I think there are so many options nowadays. As long as they are HIPAA compliant, I don't see one that is, clearly preferred over the rest. Javed?
I couldn't agree with you more, Brian. And I think it really has to do with what we talked about. What are you doing? What are your needs? What fits well with your patient population? Right? I mean, so if if you have program X that can only be run on, let's say, a Windows device, and a third of your patients use iPhones, that's going to be a real problem for you, right? So that's for us. I've worked on so many softwares, I can't even begin to tell you. But for me, it's interoperability is incredibly important. As Brian said, ease of use. Right? You don't want people to be constantly entering in a username and password every single time. I mean, that's just, it's going to cause a great deal of consternation. Also, this is a little bit more advanced. We ask the software, what's your compression technology, right? So, and the reason why that's important is that in our office, we have fiber. So we're getting huge amounts of bandwidth, right? Someone might be on a phone connection as opposed to a internet connection or a broadband connection. Well, if you have a software that allows for good compression, it's not going to mess up either one of yours. It's going to scale your audio video to the bandwidth that you have. That might be getting a little too technical, but that's incredibly important. So what are you doing, and does it fit in what you're doing?
Oh, that was very interesting. Thank you, gentlemen, so much. I really appreciate it.
Absolutely, happy to.
Thank you for all the great questions.
Great.
Hey, this is
Go ahead,
Yvonne. Hey, so I was wondering, have you all seen your compliance with medication with your patients increase since you started or been using the telehealth?
Brian?
It's such an interesting question. And I don't know that I have a clear answer. We haven't looked at it in any formal or objective way. My gut sense, Yvonne, is I think it's a fascinating question. And I think it's been variable. I have seen some individuals who have really struggled with adherence since the pandemic started. I don't attribute that to the use of telemedicine. I think just people's lives have become more complicated, and a lot of people have been through a really tough time. I've also seen other individuals who are joining me regularly through video or telephone visits and are doing great, and maybe they're working from home and maybe they've got good home support and they're doing really well. So my gut sense is it has been variable and not consistent, but I haven't looked at it objectively and I don't know the answer. I'd be curious, Javed's experience, and honestly, Yvonne, your and others' experience, I'd be curious to hear.
Yeah. Okay. Thank you.
For us, I've been seeing patients, for a long time, since 2002, HIV patients with telemedicine. So I really don't feel there's been a change with regards to compliance. However, what telemedicine allows you to do is things like DOT, right? So we actually have, some patients who have direct observational therapy that they connect. An MA or someone's on the other side, they watch them take their medications, great. Some of our other patients who are on TB meds, they actually take a selfie every single day of them taking their medications. So, I think it can work both ways, exactly some of the concerns that Brian was talking about, but I think you can use that technology in order to actually enhance compliance as well.
Okay.
I think it's a really good point. Just adding a thought to that, and one advantage of video is you also can say, show me where you keep your meds, or show me. And I have seen a couple like just tables piled with old medications that clearly needed to be discarded. So again, that sort of window into a person's home environment can be useful if they're comfortable showing you and talking about that.
What I find is the patients who complain about the number of pills of their HIV medications, when you connect them at home, you find out they're taking 57 vitamins a day. Okay.
Yeah. Thank you.
Absolutely.
Thank you for the question.
You're welcome.
Great. Well, I just want to say thank you so much to our two excellent speakers today for answering all the questions. I'm sure there's more questions, but we can filter them to you as needed and follow up, and certainly continue to engage with these great subject matter experts. And we encourage everybody to reach out to myself and Anna if you have additional follow-up needs. I just wanted to share before we wrap that we have two upcoming sessions, as I mentioned. We have our second webinar of this telehealth program. It's called Lessons Learned and the Future of Telehealth in 2022. And we have two great speakers, somebody from the Northwest Regional Telehealth Resource Center, Nikki Parisho, and then also Dr. Graywall, who's with the University of Florida in Jacksonville, a current provider doing telehealth and HIV work. That will be a CME CE accredited webinar. So please invite your providers at your site if you are interested, and share the registration link. And then our third TA session is coming up also on Zoom around the HIV client experience. And we'll have Dr. Dima Dendachi, who is with the University of Missouri Care, the medical director there, and done a lot of research into client experience, especially HIV clients. And then, as I mentioned, we have a telehealth navigator as well, Alishba Basil, and she will be speaking about navigating clients onto telehealth. So we will be sending these out by email, but I just wanted to put this here for the recording and encourage everyone to share with your colleagues in this cohort. So that's the end of our session. Just thank you again so much to Javed and Brian, our two excellent speakers today, and really enjoyed this session and want to thank you so much for participating.
Thank you.
Thank you for having us.
Thank you, everyone. Have a great rest of your day. Take care.
Take care.
Thanks. Bye.
Bye-bye.
All the best.
Bye-bye.